Test.
Right? And let me get you a music stand, Mike, so you can have something to rest your.
For all you baseball fans, I just need you to understand that, like Yogi Berra, they say I'm in a slump. I'm not in a slump. I'm just not hitting. Okay, I'll try. Thank you.
All right. Welcome, everyone. It's great to be here today, and it's my pleasure to welcome our special guest, who is a fellow brother here at Emmanuel, Mike Weiss, and today he's going to talk from experience and from his own knowledge as an expert on the whole subject of dying. And I'll let Mike introduce himself a little bit more as we go on. Yeah, we have handouts that Doug is passing out. If you haven't gotten one, raise your hand, and he can get that to you. Also, Doug has some cards. If you have questions and you want to jot those down, we can collect them and then go through them at the end. We'll try to leave some time at the end for questions. Also, this is all the time what we have to talk about this whole question of last things, cosmically and personally. There was a lot that didn't get said. If you want, I have an article that can kind of give you a biblical perspective on the new creation. If you want to read about that, what the Bible says about the new heavens and the new earth, let me know. I've got about 20 copies. It's a little bit longer reading, but I think it's accessible and it may be interesting to you as we wrap up here. Would like to just start with a Bible passage and then say a few words, then we can have a prayer. This is from 2 Corinthians chapter 4. Since we have the same spirit of faith, according to what has been written, I believed and so I spoke. We also believe and so we also speak, knowing that he who raised the Lord Jesus from the dead will raise us also with Jesus and bring us with you into his presence. For it is all for your sake, what we do, so that as grace extends to more and more people, it may increase thanksgiving to the glory of God. So we do not lose heart. Though our outer self is wasting away, our inner self is being renewed day by day. For this light momentary affliction is preparing for us an eternal weight of glory beyond all comparison, as we look not to the things that are seen, but to the things that are unseen. For the things that are seen are transient, but the things that are unseen are eternal. This is a passage that I often use when I'm visiting people who are struggling in their bodies. Struggling sometimes at the point of being ready to die. And I share this passage with them to the end that, like Paul was writing to the Corinthians, so also they might not lose heart, so they might be encouraged. And Paul is talking here about some things that, if we focus on them, could end up being very discouraging. The weakness of our mortal bodies, our outer self wasting away. When you look at that, it can be very discouraging. But Paul invites us to look elsewhere. He says, we have an eternal weight of glory prepared for us as we look not to those things that are seen, but to those things that are unseen. And what I think Paul is talking about there in terms of things unseen is God, of course, and the promises of God that have to do with the future. And because they are in the future, they are not yet, and so unseen. But they've been promised to us, and they've already come true in Jesus through his death and resurrection. And what happened to Jesus, he has also promised to all who will trust in him. And so that's where we look, even in our time of dying. We look to those things that are unseen, to God and the promises that have come true for us. Even as we today take an opportunity to look at the death, and the end of this mortal life, we keep our eyes fixed on those promises that God has given to us and prepared for us through Jesus Christ. So let's have a prayer before we turn it over to Mike. Lord Jesus, we thank you and praise you. We magnify you. We rejoice in the salvation that you've accomplished for us. We thank you for the lives that you've given us to live here today. And we thank you that as we look to the end of our lives, that we can look with peace and hope and confidence. We thank you for the ministry of those who care for people at the time of death. And we pray that as we listen to Mike today, that we would be enlightened and encouraged, not only in our time of dying, but to minister to those in their time of dying too. We pray that you'd give us your spirit today as we listen to Mike, and commend all of this into your hands and trust that you'll be with us, for we pray in your holy name. Amen. All right. Mike, please.
Thank you, Pastor.
You bet.
It's a terrifying joy to be with you this morning to talk about this. I really won't spend much time talking about that horribly uninvited guest death. Rather, I prefer to talk about the wonderful awesomeness of dying, that time that comes before the last breath. So with that in mind, let's kick off. Firstly, I have a couple questions for you, and I fully expect a response, even though it's Sunday and it's a little bit tough to talk about this. So, do we know when we are dying intuitively? Yes, raise your right hand. No, raise your left hand. That's just too tough for a Sunday morning. Okay, do we intuitively know when we're dying? Okay, those of you who...
No, right hand is yes?
Yes. Do we know intuitively when we're dying? Okay. Do we not know intuitively when we're dying? There's a small number that believe we don't intuitively know. For those of you who don't think that you'll intuitively know when you're dying, would you like to be told by somebody else that you're dying? Okay, that's pretty good. About what I expected. I believe from my 30 years plus of working in hospice that in fact we do intuitively know when we're dying. And if we don't, it's better to be told that than not. And there are reasons. There are reasons because I think once we know that we're dying, that opens the beginning of a time period that I refer to as precious time, when there are opportunities for personal growth at end of life that are largely manifested in relations, how we spend our last days relating to the people that we love, the people that we care about, to our communities, to our congregation. And I believe that when we do that, when we have discussion, when we relate to others, when we try to tie up our loose ends, we can positively impact our last 1 to 2 weeks. There's no science that I can give you that supports that, but I'll try to build an argument that it does. Thank you for that. Let's move on and get started. Just a few boring definitions. To be certain, we're talking about the same things. What's death? It's an individual who has sustained either irreversible cessation of circulation and respiratory function or irreversible cessation of all functions of the entire brain, higher brain and brain stem. Coma is a state of being totally unaware of self and surroundings with inability to respond meaningfully to stimuli. Brainwave studies suggest, however, that in that state, immediately before the last breath, we're still able to hear. Delirium we're going to spend quite a bit of time talking about because that's what gets us on the difficult road to our last breath mostly. Delirium is the acute onset offset syndrome. That means it's like turning on a light switch or turning it off. That consists of severe disordered cognition, attention, perception, packaged with a bunch of undesirable behaviors. And then last, what's palliative care? Is that a familiar term to all of you, palliative care? For those that it's not, it's team care. The team consists of multiple specialists, physician, advanced practice nurses, RNs, home health aides, medical social worker, therapists of all types, chaplains, pharmacists, and then psychologists, psychiatrists. The palliative care team can either be hospital-based, community-based, or both. If it's a community-based team, it's usually part of a hospice program. Palliative care is always patient and family-centered. It's mind, body, soul-oriented. Palliative care takes on total symptom burden management. And we all know that we can suffer from symptoms related to physical, emotional, psychological, spiritual problems. What does success with palliative care look like? Success is reintegrating broken spirits and bodies, reintegrating broken families. And so, bottom line is, when palliative care works out well, quality of life is enhanced, not necessarily quantity of life. Palliative care teams help us navigate a very complicated medical healthcare system, and I think most importantly, assist with education regarding the meaning and the anticipated outlook of disease processes. And that then permits more important discussion about appropriate goal of treatment setting and talking about, in a truthful way, what really we're dealing with. This is the time for dying for beginners. I hope you love it.
I want to tell you what normally happens as someone is dying. Dying, just like being born, is a process our bodies go through quite naturally, with recognized phases that are pretty much the same for everyone. It's all very ordinary. At first, our bodies grow weary. We need more sleep, less food. We may lose our appetite altogether. Some days we can manage an outing or visitors or watching TV. Other days we mainly sleep. All this is normal. Inside our weary bodies, changes are happening. All our systems are running out of energy. Digestion slows down. Our heart may not pump as strongly. Our organs might slow down. All normal. Aside from the physical, I've noticed that dying people's perspective often shifts from themselves to others. The same last messages. I'm sorry. I forgive you. Thank you. I love you. Most people are not conscious by the time they die. We don't know when we're unconscious. We don't notice time passing or feel our body. It doesn't feel like going to sleep. It's just a state of non-awareness. To begin with, dying people might only be unconscious some of the time. In between, they may wake up and talk, or sip drinks, or listen to the people around them chatting. That's normal. They may become a bit muddled or restless. It helps when people hold their hand and talk in soothing, gentle tones. Familiar, trusted voices calm and comfort. Unconscious people breathe in an unusual way. Their breathing pattern gradually changes backwards and forwards between deep and shallow and between fast and slower breaths. This is normal, and they can make unusual noises. If their breath vibrates their voice box, it might sound like a sigh or a moan. Sometimes their breath gurgles or rattles. It's not uncomfortable. It's a completely normal part of dying. Hearing is the last sense to go. That's why loved ones and caregivers can keep talking while the dying person is unconscious. It's why some people make end-of-life playlists. What about the moment of dying? Well, it's usually very gentle. Our breathing gets slower and more shallow, and then it just very gently stops. A few minutes later, our heart stops too. That's it. No fuss or fear or panic. Of course, saying goodbye to people we love is sad, but knowing what to expect takes away a lot of the fear. I've met so many bereaved people who wish they had talked about dying more. I've never met a person who regretted having those important conversations. We need to talk about it, because talking about death will help us to live together better.
Hopefully you all have a handout. I didn't find that until last week. So no. I didn't find a lot of things until last week. But did you know there's End of Life University on YouTube? It's fun checking out. Many of you may have encountered that little blue booklet from our local hospice, VNA hospice program, that they hand out to help educate people about what's happening and why it's happening so that there are less surprises. Well, you can go to End of Life University and see the 80-plus-year-old authoress of that little booklet talk about her husband Jack's death in the last 2 or 3 months, and despite her decades of working in hospice, she didn't see it coming. But the hospice nurse did and was able to help her with that. You can also find a whole bunch of information from a doctor by the name of Ira Byock, who I first heard speak in 1994 at the first National Hospice and Palliative Care meeting in San Francisco. He's written a lot about end-of-life care, and his book from the 90s entitled Dying Well still sells and helps people. And it's from him that we get these last things to say to each other that really help bring our lifetimes to more peaceful ends. Please forgive me. I forgive you. I love you. I thank you. And then a fifth, a form of goodbye, a goodbye from the care receiver to the people that are caring for them, but also the carers saying to the person departing, I'll be okay. When it's time for you to go, it's okay to go. And for some reason, having that kind of conversation near the end of life is very helpful. That get to your question satisfactorily? Okay, all right. You should have this little diagram. This comes out of the world of taking care of mostly men, but men and women dying from AIDS. And a lot of the work out in California at a very large hospice program in San Diego. What we've just seen on the video is the usual road. That's what about 19 out of 20 of us get, or 95%. We get that very natural, peaceful appearing, not at all terrifying, active dying period. 5% of us get the difficult road. So these two roads I'm showing you are the period of irretrievable dying. Hospice workers usually refer to it as active dying. So we're really not normal when we enter these last 1 to 2 weeks. But the notion is that if we wanted to stop what's happening, we're just unable. All of our advanced medical therapies cannot stop irretrievable dying. I believe that it's very important, however, to talk more about dying. If we're going to be able to do that, we've got to do it out here to the left before we get to the last 1 to 2 weeks. And so I guess that's the part of dying that we need to call inactive dying. If the last 1 to 2 weeks are actively dying, then the rest of it, I guess, is inactively dying, for lack of a better term. But I like to refer to it as precious time. And precious time for many reasons. The difficult road is characterized by bad terminal restlessness. Is that a concept anybody's familiar with? For those of us that aren't, it's a set of signs and symptoms that include agitation, confusion, emotional distress, with outbursts, oftentimes angry, absolute lack of attention to surroundings, unusual agitated behaviors like pulling out IVs, removing other tubes, removing garments, undressing beds, jumping out of bed and running around the bed. The worst I saw was a gentleman who managed to get out of bed and lay down and obstruct the doorway into his room for hours. No way to console him. All part of this very difficult terminal restlessness. It can actually progress to more frank psychosis with hallucinations. And as things progress, it's often accompanied by myoclonic jerks, unanticipated jerking of extremities, and then, thank goodness, rarely seizures. It's a process of dying for some of us that results in physical changes that can be mentally, emotionally overwhelming. The things that tend to contribute to it include decline in function of liver and kidney. We're no longer able to process body waste and metabolic products of the drugs we've been ingesting. Other things that may fuel an aggressive or bad terminal restlessness are thought to include leftover toxicities from chemotherapy and radiation therapy. Other things that commonly accompany us to our last breath, like anemia, infection, fever, dehydration, tend to pour gas on terminal restlessness. And then there's urinary retention and constipation, things that distend our bladders and our colon. That tends to aggravate terminal restlessness. And then there's the concept of total pain. If unidentified and or poorly managed, seems to be the most potent contributor to the bad road to our last breath. So I don't think any of us would choose that road. Most of us would hope for the usual road. But I believe, after having talked with people for an extended period of time and then witnessing what happens to folks, that there are some things that we can do in our precious time that will point us toward the usual road and perhaps away from the difficult road. And so I've tried to list those on your handout, and I apologize for my handwriting. But there are some things that I think are of value to talk about and to plan for. Once we know, either because we intuit it or somebody has told us that we're now in our dying time. There's a fellow by the name of Samuel who published an article in Psychology Today online who makes an attempt to summarize how Americans have processed and dealt with dying. It's interesting to look at. We don't have the time to go through it completely. But to make a long story short, we can know that 400 years before the Common Era, a fellow by the name of Hippocrates, also known as the father of clinical medicine, stated, "Young men fear death, old men fear dying." It's the dying we're talking about. Follow around all of the things that have happened in this country, anywhere from who wrote the first living will to when hospice care came over the ocean to the East Coast from the UK, through the court decisions about our personal autonomy to control some things at end of life, like rejecting recommended medical therapies, all the way around to past 2 or 3 years, where we're now seeing things on Broadway like Assisted Suicide, the musical, or watching on our TV screens Me Before You, which is visually a very stunning movie about a young man in England who has an accident. He's now quadriplegic because of a cervical spine fracture. And he's decided that quality of life is unacceptable. Makes a trip to Switzerland, gets put on the euthanasia list, and then goes home for 6 months to do that time so that the people that are going to end his life in Switzerland can be sure that this is what he wants and he hasn't changed his mind. Dad supports him, Mom doesn't. Mom hires a beautiful young woman to participate in his caring. And the bulk of the movie is his transformation from being somebody who's just shut in his room, not engaging with the world at all, to coming out and doing what you and I feel would be fun, invigorating activities. The girl, of course, falls in love with him and tries to persuade him not to finish his plan, and he ultimately says to her and to his mother and the rest of the world, no, I'm in control, and off to Switzerland he goes and gets put to death. So that's the conversation locally, but also worldwide. I think it's misguided, but now it's being referred to as dignicide. We have currently in this country, I think physician-assisted suicide is now legal in 7 countries. Oh, I'm sorry, it's 9 states in the U.S. plus the District of Columbia. So we continue to struggle with this notion of dying. We were I think misinformed and pretty naive to think that we can actually manage it. It's just part of our natural lives that is unmanageable. But nonetheless, here we are, and Samuel at the end of his article comes to the conclusion that we're in trouble as a society because folks like me, baby boomers, are about to die in historically high numbers, and we've taken few steps to prepare ourselves. And then there's the competing narrative of immortality and radical life extension movements that are getting in the way of what I think is a valuable conversation about dying. It's not that long ago that we died at home with the care of our family from pneumonia and other infectious diseases. The kids took care of us, taught their kids about dying. It was just all so very clear and part of life. Nothing mysterious. Then we get into the mid-20th century and all the marvelous improvements in medicine, and by the 70s, 70% of us are dying in hospitals with very aggressive care. Now the pendulum is swinging back the other way with hospice end-of-life care as an alternative, and with most Americans saying, if I know I'm dying, I'd rather die at home with the care of my family than in the hospital, isolated from my family. We're swinging back to a majority of Americans actually dying in the home setting. In my opinion, not enough with hospice care support or with hospice care added as an afterthought right at the end of life, right at the point of irretrievable dying. Hospice care has so much more to offer than that. It's the palliative care we talked about plus. And there's ample evidence that the sooner we elect our hospice Medicare benefit, not only will our last days be more comfortable, but chances are very good we'll have more of them. We'll have more time to enjoy with our family and loved ones in a very comfortable way. So, where do we stand today? 20% of us will have no time to plan our last days. We'll die suddenly. Get hit by lightning, get hit by a truck, by a train, suffer a massive MI, massive stroke. The event happens, and then we're dead. No time to talk about dying, no time to make plans. But the majority of us, the other 80%, will die from one of those chronic illnesses. heart disease, lung disease, the leftovers from multiple strokes with disability, just advanced age with frailty and multiple comorbid conditions. We'll have plenty of time to talk and plan. Probably months, if not more. Chronic illnesses tend to follow distinct trajectories toward the final 1 to 2 weeks, the irretrievably dying time. And that fact enables carers, physicians, to actually make reasonable and sometimes accurate predictions about how much time we have left. So that's what I mean by prognostication. It's a very imperfect process attempted by mere mortals. It's a medical judgment. It's an opinion, but it has value. It provides framework to make informed decisions about the types of care we receive at end of lifetime. Having a prognosis opens the door for life care planning on multiple fronts: spiritual, financial, psychosocial, life evaluation and closure, and then legacy planning. But there are a lot of moving parts in terms of making a prediction as to how much time do I have left, or do you have left. First, there's the diagnosis. Is it actually an accurate diagnosis? Is that disease actually life-limiting with maximal treatment? And then there are other factors, most importantly including depression and social isolation. We know that those factors independently lessen our days, shorten our prognosis. And then there are the spiritual beliefs that are known to improve outcomes. And so when predicting how much time a patient has left, physicians are looking at all of these things, and then if willing, are giving an estimation. So to summarize, depending on the unique circumstances of each person, of each of us, there's a pace or rate of change that can vary substantially. So if there's a group of 5 people here dying from congestive heart failure, they're not all going to die in 92 days and 12 hours. It's extremely variable. But having acknowledged that, there are recognized patterns of decline toward end days that are helpful in predicting time. We have this knowledge, and this knowledge is empowering. And if we teach patients and families about what can happen and when it might happen, it's more often reassuring as the illnesses and problems progress. That is to say, there's less risk of fear and anxiety overwhelming folks as dying happens to them, because we have told them about what may happen, when it may happen, and as Dr. Mannix said, that it's all just very normal. So attending the question, how long do I have, doc, is a crucial thing to do despite all of the uncertainties. The uncertainties were highlighted by a study a few years ago in Chicago. 326 patients dying with cancer in 5 different Chicago hospices. These people asked their carers, how long do I have, doc? Only 37% of the carers were willing to give a frank estimation. Of those 37 estimators, 20% were on target, 80% were wrong, usually by a lot. And the bottom line is that average survival time for these patients was 26 days. When carers predicted, they predicted on average 90 days. And the closer the carer was to the patient, the more likely they were to be erroneous in their best guess. So what's of value? Understanding that we're very unique, how we respond to our unique end-of-life diseases that are usually chronic. Understanding that the carers that are attending us are all wounded in their own way and mere mortals. What's helpful? This question has been validated as helpful. I can tell you that if you have the courage to ask a carer who really knows you and has taken the time and effort to understand what's important to you, what you value, pay attention to all of your chronic diseases and comorbid conditions. If you ask that person, "Doctor, would you be surprised if I die within the next year?" And the physician says, "Yeah, that would shock me," then you're probably still in that very inactive dying time period that I alluded to. On the other hand, if the response is no, I would not be surprised if you die within the next year, that's a very powerful response that is a valid response. And the meaning of it is you are in your last year of life and probably significantly less than that. So for those of you who are comfortable intuiting that you're dying, it's probably not necessary to ask that question unless you need validation. But for the rest of us, if we have the courage, it's a meaningful question to ask. It opens the door to our precious time to have the conversations that can help guide us to the usual road away from the difficult road. Want a little bit of time for questions, so let's move on to this picture that I think I gave you that characterizes the types of care that we receive. And if you'll look to the left, that's where our chronic illness that ends up being our life-limiting illness starts. And for most of us early on, the care that we get is referred to as disease-modifying care. Sorry. And because it's early in the disease process and we're not burdened by too many symptoms, we're not getting a whole lot of palliative care. All of our tests and treatments are designed and oriented to make that accurate diagnosis and then to do something about it so it doesn't shorten our lives. But as is true for 80% of us living with this chronic disease, eventually the disease has its way with us and things get worse. We're now burdened by more symptoms. Our treatments aren't working as well. And as we move toward end of life, most of the care we get is symptom management care, trying to lessen our burden of suffering. Less pain, more fun. And the amount of disease-modifying treatment is less because it's simply not working as well as it used to, or it's not working at all. Ultimately, though, our chronic disease progresses to last phase, the terminal phase of illness. Now we're talking not about years of chronic disease, but we're talking about the precious time period where your carer has said, "I'm not going to be surprised if you die within the next year," which means you're probably in your last 6 months. That's the time to think about electing palliative care plus. Palliative care plus is also known as hospice care. For those of us who are Medicare beneficiaries, it's a subset of our Medicare Part A insurance. It's an entitlement program. We can choose to either continue care in Part A, which is predominantly disease-modifying restorative treatments, or we can elect our Medicare benefit, which is predominantly palliative care treatments. Sadly, to this day, we can't have both simultaneously, so it's an either-or choice. But if we choose the Medicare hospice benefit, there's ample suggestion that we will live better and probably a little bit longer. That's been established by the effectiveness studies on the benefits of palliative care. And then the last type of care, bereavement support, is out there to the right. That's part of hospice. It's not part of customary palliative care teamwork. It has to do with caring for the ones we leave behind, and can be very, very effective and helpful in terms of bereavement support. What's comfort care mean? Where does that fit in? And the best I can tell you about comfort care is that's for people who don't want to talk about palliative care or hospice care. They're seriously ill, and they know it, and they don't like it, and they're suffering from it. But, you know, I'm not dying. I don't want to talk to you about palliative care. That's what hospices do. Well, there's comfort care for those of us that are in that place. And I kind of put that right up near death, just inside the hospice care part. And oftentimes that comfort care is happening in the hospital when the doctors have finally said to the patient and the family, well, there really isn't anything more we can do to make the disease any different than it is, and we really expect death soon, and let's transition to making sure that our loved one is as comfortable as possible. So there's a very clear-cut differences between disease-modifying therapies and palliative therapies, and the top lines clarify that. The disease-modifying treatment, the goal is cure. The ultimate failure is death. For palliative care, the primary goal is relief of suffering, and success looks like people are living more comfortably and having more fun. So the goals of treatment are different. I've tried to make the case that 80% of us will have time to plan, time to talk about dying, time to try to organize such that our dying looks like, smells like, and tastes like something that we would prefer. And it is clear that good hospice programs can help us with that. Pretty much out of time, and so the last thing I want to caution you about is hospice programs are not all alike. At the beginning, they were all pretty similar, but that's when it was mostly a grassroots movement. It wasn't doctors and nurses in charge. It was just people caring for people. But then the Medicare hospice benefit was passed in 1983, and money became part of all of this. And if you want to be frightened by it all, look at how hospice became a for-profit hustle, written by Ava Kaufman, published in the New Yorker last fall. I think it's number 2 there. It's really, really quite disturbing. But having looked at that, I would encourage you to read things from Ira Byock. He's still of the opinion, some 30 years later, that hospice is worth saving. And I am too. But if we acknowledge that 5% of us get the difficult road, an important question to ask a hospice program, I think, is how do you care for your patients that are on the difficult road to last breath? And they ought to tell you, well, they go into hospice hospital. They go inpatient where there's full-time nursing care, and this is what we do aggressively to manage symptoms. If they say, well, that never happens to our patients, and everybody gets cared for at home, then maybe that won't be the best choice for you. So just a word of caution about that. And then we can visit government sites, and they'll give us lists of questions to ask hospice programs in order to ferret out which one might be best for me and for my family. And I think I better stop.
We've left some time for questions, and I don't know, Doug, did you collect anything? Okay. Maybe, yeah, if you have a question and you want to pass it to the center, otherwise, just by raising your hand, you can.
Are slides available? I noticed the content wasn't in the handout.
Are these slides available? You can share it. Yep.
I also have a few paper resources, if that's where you're
Yeah, you can just share the digital version or make copies, but yeah. Mm-hmm. Other questions? Yeah, Paula.
I just want to make a comment. As an English teacher, Me Before You was based on a wonderful novel by Jojo M. Moly-X. If you're interested, Mike talked about the movie. I didn't even know there was a movie, but it's a wonderful novel.
Okay. Yeah, the movie Me Before You that Mike referenced was based on a novel, and so you can read the story as well. And if you like to read, it's worth reading. It's a good novel.
But I also want to say that I experienced hospice 3 times recently. For my husband and both my parents. And they were some of the most wonderful experiences that I've had. And they weren't the same hospice programs. Mine was different from my parents. I also want to say that having the pastors come at end of life, and that too is an experience that you will never forget when that happens. And until you've experienced it, it's hard to.
Yeah. Yeah, so just to repeat what I heard, I didn't hear it all. It was, but yeah, that's okay. But talking about the helpfulness of pastoral care at Life's End, part of managing that concept that Mike raised of total pain. You know, there's the spiritual side of things and needing to hear from God, a word from God in their time of dying. And that's what we're called to do, to speak for the Lord and to take the prayers up to the Lord and know that He hears us. Yeah.
Mike, would you say definitively how soon should people contact hospice when death is imminent?
So, yeah, when do you, just to repeat for Doug, how soon should you contact or arrange for, start the conversation about hospice care when you know that death is imminent or even, within a year?
My opinion is sooner is better than later. So our experience locally was that the median length of service provided to hospice care recipients was 9 days. And what that means is that 50% of people that came under our care died in 9 or fewer days. They were all on the last road, either the difficult road or the usual road. Hospice has so much more to offer than just treating symptoms related to the last week or two, that the sooner the better, I believe. And so my response would be, once you intuit that you're dying or your carer has said to you, I won't be surprised if you die within the next year, that's an appropriate time to start a conversation with a hospice program if that's what you want. Yes, Dottie?
What do you have to say about people who are
their qualification knocks them out of hospice care, and then they go back in as symptoms change.
Well, firstly, our benefit is ours. We can elect it or revoke it, and we can do that as often as we want. So recently I had a friend who elected his hospice benefit, and then they came and he decided that they weren't doing enough and he didn't really benefit from it, so he revoked it. I don't think it's changed the fact that he's in his last year, but I say that to highlight that it's something we can elect and revoke recurrently without issue. There's the issue, though, of diagnosis. Do we have the correct diagnosis? And is that, in fact, a life-limiting disease? The benefit states that, to the best of the physicians, at the beginning it requires 2 physician opinions that the patient is in last 6 months if the disease follows its usual course. Well, if we're not on target with the diagnosis, and it's not a life-limiting illness, and it takes us 9 months to figure that out, then the program can discharge the patient because the prognosis is no longer 6 months or less, and they don't meet criteria for hospice. So we can't know these things, as you know, Dottie. It's, we're not permitted to know everything. Do I have time to read? There's a card that was sent up. During my father's last few hours, I continued to hold his hand in mine. I talked with him even though he was in a comatose state. That's what the pathway shows us. Before our last breath, we're unconscious, we're comatose. I talked about our adventures together over a lifetime. I assumed he could hear me. I believe he, in fact, did hear you. At his last breath, he gave me a firm grip of the hand. I said this was his last goodbye, and that's what I would choose to believe as well. He heard every bit of it. He just wasn't able to say it in a way different than that last squeeze. Carla?
Does the family or the patient themselves have to request hospice care, or can the physician suggest it and to the families?
Well, both are very appropriate. One of the hospice myths that I think leads people to delay is that they believe the physician has to recommend it. That's just not true.
We got time for one more.
I just want to underscore that you mentioned that little blue book. That probably is the most helpful piece of information. I went through that with my mom and dad.
Yeah, Phil is talking about a little blue book that, there it is.
Gone from my sight. This is by Barbara Carnes, the lady I told you about. You can go see and listen to on End of Life University.
Okay.
Talk about the recent death of her husband.
Is that book available?
Well, I confess my ignorance. I've been out of work for 7 years, and I don't know what local programs are doing, but while I was working in hospice care, it was pretty universal that all the different hospitals shared that booklet with people because it's well written and I think helpful.
All right, that's all the time we have today. And if you have more questions, I'm sure Dr. Weiss would be happy to talk with you further here in the gathering space. But thanks for coming. And as I promised, for anyone who's interested to read a little bit more about the cosmic perspective, right? We've been focusing on the personal, but the cosmic. The title of this article is "Daddy, Will Animals Be in Heaven?" Subtitled "The Future, New Earth," and written by an Old Testament professor of mine and Pastor Kegley's, who is now actually teaching out in Arizona in his retirement. But I'll leave these here for anybody that wants them. And let's give Dr. Weiss one more round of applause. Thank you. And so our adult Bible class will be, we won't be having it for the next couple of weeks. We'll pick up again, I think on January 7th we'll be starting. And look forward to hearing from Lisa Driver, professor at VU, who's going to be talking about Christology, the doctrine of Christ and his person and work. So hopefully you'll join us for that.